to be able to deal with those consequences. And ACLS, which is really basic advanced cardiac life support, really is essential to being able to deal with some of those potential complications. And airway management allows one to be able to deal with the airway complications that are very, very common. And you know, one thing I didn't mention is, other than the hypoventilation, the lack of breathing, and the diminishment in respiratory drive, the ability to breathe, is obstruction of the airway that can occur. And some patients are more predisposed to that than others, particularly those that have sleep apnea, for example, where the tongue, where you lose that tone, muscle tone, with the use of this medication, and the tongue flops back and the airway obstructs. So there has to be an understanding of how to manage from very basic airway issues, such as extending the head, thrusting the jaw forward, or chin lift, to being able to establish somewhat of an artificial airway, to delivering more oxygen, to finally being able to provide an artificial airway, meaning placing a breathing tube and being able to deal with that if that was to become necessary.
And can you describe, I know with your hands you made a motion of tilting the head back and doing a chin lift. Can you describe what those two things are?
Yeah, those are very basics to really being able to really secure the airway and eliminate the possibility of the upper airway obstructing, meaning the tongue flopping back and the airway closing up as a result of the tissues in the back of the throat. So by basically extending the head and pulling the jaw forward, you actually increase that space that is in the back of the throat. We see this all the time when we use some other sedatives, when we do procedures like bronchoscopies, where we use drugs like Versed and fentanyl. We see that suddenly patients, their breathing slows down and their oxygen saturation goes up, and really doing that jaw thrust really helps really open up that space in the back of their throat and allows them to ventilate, and allows that effect of that medicine to wear off, and the level of sedation to be less deep than what was anticipated. So there always should be preparedness when you're using, for example, moderate sedation, that the patient may go into deep sedation and even to general anesthesia. And certainly if you're using deep sedation, you should be well prepared to deal with the possibility of someone going into a state of general anesthesia.
And the chin lift that you indicated, is that part of the same technique?
Right. Chin lift and jaw thrust really, I think, are go hand in hand, but jaw thrust is really is critical in terms of helping reduce the obstruction in the back of the throat.
You also talked about the need to have to always have the presence of additional bedside nursing assistants, and the lack of such assistance you found to be an extreme deviation. Is that correct?
Well, the setting where I understand that, for example, anesthesiologists use propofol for what's called MAC.
And that's monitored
anesthesia care. I apologize.
Just a moment, please.
Yes.
We're talking over each other. Let's wait for one speaker before we respond or ask another question.
Sure.
You mentioned MAC, and I did.
Right. In those scenarios, it's when it's used, it's very important to have a nurse at the same time at the bedside. Now, as I explained earlier, there are times in critical care medicine where emergencies happen in the hospital, where we respond to somebody that has stopped breathing, and it's an unforeseen event that occurred because somebody had an acute heart attack who was there in the hospital for another reason. And in those scenarios, we may not have a nurse present, but normally in the intensive care unit, we always have a nurse present. They're actually part of the care of being in the ICU is having more vigilant, sometimes one-to-one nursing coverage, meaning one nurse to one patient, so they are really able to deal with all the complexities and all the different things that they have to do and really pay good attention to that one patient who's critically ill.
Thank you. Now, but in this case, you comment on the need for Dr. Murray to have needed to have additional bedside assistance, and the lack of it was an extreme violation.
I think in this scenario, clearly it would have been helpful and would have provided that additional support. Somebody that was providing the anesthesia, providing the sedation, and somebody that was actually able to monitor. So it allows you to really be able to not do two things at once, to really be able to pay complete and utter full attention to our patients. I think,
and of course,
yeah.
Of course, it's absolutely essential if you're going to be a doctor that's going to leave the patient and leave the room, correct?
That's obviously without saying. That is clear. That is really the really fundamental basics of the Hippocratic Oath, or kind of the ethics and morals that physicians swear by. Is first rule is to do what's right for your patient, not to abandon your patient. Absolutely.
Not to what?
Abandon your patient.
Now, you also mentioned pre-procedure setup. And again, as it relates to this particular case and the facts you've reviewed as it relates to Murray's treatment of Mr. Jackson, what did you conclude regarding pre-procedure setup?
Right. There are really some basics that need to, like I said earlier, in critical care medicine, I'm sure anesthesiologists would agree, it's always imperative to be prepared and be able to deal with the challenges and unforeseen circumstances that may arise. And that is part of that. It's being prepared when you are using a drug that can potentially have untoward effects. And it's very hard to predict what those effects are. It is even more so important to make sure that you have certain capabilities. You have continuous heart monitoring, continuous EKG monitoring. You're able to have a non-invasive blood pressure device that measures blood pressure at least I would say every 5 minutes, to really show where your patient is going. I mean, we know in these situations patients are dynamic, meaning things are changing every second, especially when you're giving them medications. And just because they look good at 1 minute doesn't mean at the next minute they're going to look equally good. So blood pressure monitoring, heart rate monitoring with a continuous EKG, pulse oximetry to have that measurement of the arterial oxygen saturation with audible pulse, as well as alarms that tell you if the saturations are coming down. Apparatus that allows you to protect the airway. One of the other untowards complications of sedation can be aspiration, where patients basically regurgitate contents in their stomach into their lungs. And that could be very, very dire. And once the airway, the breathing tubes, fill up with whatever it is that was in the stomach, you sometimes are not able to ventilate them. You're unable to deliver oxygen and move carbon dioxide, and patients can die. So it's very important to be prepared for aspiration. So you need to have a suction catheter. Suction catheter in the hospital is very easy because there are devices connected to the wall, and you connect the suction catheter, and you're able to, when you're doing that procedure or you're giving sedation, to suction the mouth, the oral cavity. But certainly if you're away from the intensive care unit, for example, in a procedural suite, you can have portable devices that apply suction and be able to suction the oral cavity in case there were secretions or gastric contents from the stomach that are regurgitated upwards. And a crash cart, the capabilities to deal with some untoward circumstances such as the heart stopping, to have medications on hand like adrenaline that basically stimulates the heart to beat, and medications to reverse the blood pressure lowering effects of some of these agents like ephedrine or neosynephrine, medications to deal with some of the fast or slow heartbeats that also can occur in conditions where patients become unstable. And then the other would be an automated defibrillator, a device that can shock patients. And that is really more applicable when patients have abnormal heart rates, particularly what we call ventricular arrhythmias, when their heart rate is such that their heart is unable to pump appropriately, and where we use that device to shock their heart out of that abnormal rhythm. So that is another component that needs to be present.
And how about
Excuse me. Let's all try to speak just a little bit slower. I know Mrs. Theodoro says it's fine, but I think we need to just slow up. Thanks.
Thank you, Your Honor.
I apologize.
How about an infusion pump? Is that...
Absolutely. If you're using propofol,
You're speeding up.
if you're using propofol, it is imperative to have a precise method of delivering the drug as a drip. It is very hard without that to know exactly how much is being infused into a patient. So having an automated pump, infusion pump, is very key. Our nurses are very familiar with it because we never have anyone who is on sedation, even with a breathing tube in, which is protecting their airway, that is not connected to a pump. And remember that these are people that actually have a breathing tube already in them. So it's imperative to have an infusion pump, which allows you to really precisely know how much of the sedative you're giving.
And doctor, you concluded in your analysis of the care Dr. Murray gave to Michael Jackson that the lack of this equipment, including the cardiac monitor, the blood pressure cuff, pulse oximetry with an alarm, suction, the crash cart, the airway equipment, the lack of all that equipment and the skills to use it represented, again, another extreme departure from the standard of care?
That's correct.
And when you're using these extreme departures in your vocabulary, in your analysis, does that equate to gross negligence on the part of the doctor?
Correct. I think once you kind of violate the standard of care, these terms you use, really the way I look at it as someone that's not in the legal world, is how far you go from that standard of care, the degree of which you deviate. And certainly extreme is when this is just something that we just would never expect to see in a similar circumstance being practiced by some prudent physician in a reasonable, in a similar circumstance.
And have you ever seen, in your personal experience, a doctor administering propofol to someone at home in the setting we've been describing?
No, this was the first time I've heard of that.
And when you conclude, as you have on these and as we go forward, that it's an extreme departure, you're concluding that you would never expect to see that from a reasonable, prudent doctor.
That's correct.
You go on to talk about the lack of medical records or charting, and you found that to be an extreme violation or gross negligence. Can you describe that and your reasoning?
Right. When patients come in for a procedure for sedation or even to the intensive care unit, one of the first things we need to do is have a basic history and physical exam on them, to know what their history is, what are their risks, what are underlying issues that they may have. That automatically allows the people caring for that patient to really use precautions and judgment. Again, it's all about being prepared, and have vital signs, just the initial vital signs. Well, what was their blood pressure, heart rate before they got any medications? So that's part of the charting. But also, once you do initiate any kind of therapy or sedation, whether it's in the ICU or outside of the ICU, such as a procedure suite where people do endoscopies, bronchoscopies, colonoscopies, it is important to chart